Welcome to this edition of The Boundless Brain. I'm your host, Hoppy Kercheval. And today we're going to talk about groundbreaking treatments of debilitating conditions like chronic pain and depression. And there are similarities in these in that they are neurological or can be neurological in some instances. But there are these treatments now that are being done at the Rockefeller Neuroscience Institute. Transcranial magnetic stimulation, TMS, transcranial magnetic stimulation. With us to talk about this and explain it is Dr. Umer Najib, director of the TMS program at RNI. Doctor, good to see you. How are you?
I'm good. Good to see you as well, and thank you for having me here.
Thank you for coming on with us. So, TMS, what is it?
TMS, as you mentioned, it's transcranial magnetic stimulation. So, as the name suggests, it's transcranial, meaning across the cranium or the skull. Magnetic stimulation. These are pulses of magnetic energy that are delivered non-invasively across the skull to the brain. And when these magnetic pulses they hit the brain, they stimulate the brain cells, also called the neurons, and force those neurons to talk to each other and strengthen the connections between each other. So TMS is a non-invasive way of stimulating the brain or changing the activity of the brain and targeting a very specific area of the brain. So unlike other pharmacological therapies, when patients take pills or injections or infusions that affect the whole body or the whole brain, TMS can target a specific area of the brain down to excellent accuracy and just change the activity of that area of the brain.
So this may get very technical, but how does it change those cells? Can you explain that?
Oh, absolutely. So it's fascinating that the brain cells or neurons, they talk to each other. The connections between the neurons and the communication between the neurons essentially involves small electrical currents. And magnetic fields, a rapidly changing magnetic field can produce an electrical field. So these magnetic pulses, as they hit the brain, go to their target, they produce a small electrical field and force those neurons that require electricity to talk to each other to indeed do talk to each other. And it's interesting, we can use these changes of the magnetic pulses or the magnetic field in various different ways. We can use them in ways where it dials up the connectivity of the neurons, or it can dial down the connectivity of the neurons. So it can either force those neurons to make the connections more stronger, to talk to the neighboring neurons better. We call this synapse. A synapse is a connection between the two neurons. So make the synapse stronger, or it can dial it down depending on how we use it so that there's less electrical activity in that region and the connection or the synapse becomes even weaker. There are certain conditions where the certain parts of the brain are less active than they need to be. So in those cases, we can dial it up. And there are certain conditions where certain parts of the brain may be more active than they need to be. And in those cases, we can dial the activity down.
And Doctor, I want to talk about in a few minutes what this can be used to treat. I want to get to that because it can treat depression. It can treat various conditions that are linked to the brain, chronic pain, and we'll get to that. But this is a fascinating treatment. How do you figure out what part of the brain to target, and how do you zero in on that part of the brain?
So there are different ways to do that. For most of the conditions where we use TMS clinically, we already know which parts of the brain are involved. We already know which neural circuits are involved. And oftentimes there are multiple parts of the brain that are involved in a certain condition. For instance, you mentioned that this is used in depression, right, and we'll talk more about how it's used in depression. In depression, we know the circuit, the neural circuit that's abnormal.
Okay.
And what we do is we target one of those regions in that circuit and dial up the activity, and that in turn dials up the activity in the whole circuit. So for most of these conditions, we already have many studies done studies with functional MRIs, with PET scans, connectivity studies, studies looking at the metabolic activity of the brain to know which parts are involved, which parts are implicated. And in those cases, we know the targets and we know what we need to do. The treatment is very individualized. So two patients will not have the same brain anatomy.
Okay.
The brain size can be different. The location of certain parts can be different. So although we may know that we need to target area A for a given problem, we still have to find out where that area A is for a given patient. And that can be done either by obtaining an MRI scan, and we can point out, or there are certain other ways where we can do what we call brain mapping. Even without the MRI, quickly in 15 minutes, there are certain areas of the brain that we know control a certain function, and from those we can calculate where the other areas may be, and we can do those calculations and do what we call brain mapping to figure out where that area A may be for a given condition or area B may be for another condition. And then we individualize the treatment according to that.
Doctor, let's zero in on depression. And there's a lot of treatment for depression. There's various medications, there's psychotherapy, there's all kinds of things. Tell me, just give me an example of a patient that you see. And you say, okay, you are a candidate for this because what? These other things haven't worked or your depression is severe. So take the story from there.
Yeah. So as you said, there are pharmacological therapies, there are medication therapies for depression. And at this point, TMS is reserved for those patients who are treatment resistant. And treatment resistance is defined as a failure or an intolerance to at least 2 oral medications. So if they have tried at least 2 medications that have either not worked, alleviate their depression symptoms, or they've not been able to tolerate it. Remember, this is a big problem. These medications, any medication that works on the brain, has the potential to cause unwanted side effects. And common side effects being brain fog, sedation, imbalance, sleep disturbance, and so on. And for patients who are highly functioning, even mild side effects can actually be functionally limiting for them, mm-hmm. right? So for patients who have failed at least 2 treatments or not tolerated at least 2 treatments, they typically qualify for TMS. And here's how TMS is different compared to the pills, because TMS does not affect the whole brain. It only targets the area that's implicated in depression, mm-hmm. and changes the activity of that area of the brain.
Explain then the treatment when you get to TMS. You prepare the patient, the treatments themselves, what you do.
Right. So before a patient gets to that point, we review the patients, we evaluate the patients, make sure that they're going to be good candidates for TMS.
Because not everyone is. Is that fair?
Correct. Okay. So a good candidate for TMS would be somebody who has tried at least 2 medications, right. and has not had a positive response to them, and who has not had a brain injury in the past. A brain injury and has not had and does not have a seizure disorder, because then those increase the risk of side effects with TMS. And provided that the patients, so we evaluate the patients in our specialty clinic that is for treatment-resistant patients, and if the patients would be a good candidate, and then the patients are agreeable to this therapy, then we bring the patients in. We have a multidisciplinary team of psychiatrists, neurologists, neurosurgeons, specially trained nurses, neurotherapeutic technicians who have gone through rigorous training and obtained certification for TMS. The first visit is typically a little bit longer, about an hour and a half, because that visit requires us to do the brain mapping, to create the treatment plan for the patient. As I said, it's very individualized for the patients. And there are 2 main components in individualizing the treatment plan, and those are, one, finding the location for a particular patient, the target location, and secondly, establishing the target dose. As I mentioned, these are magnetic pulses that go across the skull.
Non-invasive. You're not opening the skull.
Non-invasive. There's no anesthesia, no medication, no sedation involved.
Does it hurt?
So there can be mild scalp discomfort.
Okay.
And some patients experience a mild headache afterwards, but these are the typical side effects. Patients, after the completion of the treatment, patients can go back to the normal activities. There are no restrictions.
And the treatments are pretty extensive. It's you got to do it multiple times, right?
Correct. So after the first visit that requires brain mapping, establishing the protocol, the dose to get to a particular patient's brain, skull thickness can vary how much dose we need to get to the brain. After we establish those things and establish the protocol, then from subsequent visit onwards, all this information is in the system, and we have already established the treatment protocol. So the subsequent treatments are shorter, about 45 minutes or so. But each treatment helps strengthen the connections, and each subsequent treatment helps the change to last longer and longer and longer. So a typical treatment strategy is that patients get daily treatments for 6 weeks. And daily is during the weekdays, Monday through Friday. So 30 treatments, Monday through Friday, so over a 6 weeks period of time. We reevaluate the patients periodically during the course of this index series. And at the end of the index series, if we see a significant improvement in their symptoms, then we classify them as a responder. That means that they have responded to this therapy. This therapy is being helpful for them. And then those patients then transition to maintenance treatments.
Okay.
And just like I often tell the patients, so instead of taking a daily pill, they're coming in and getting these treatments. But just like for any chronic disease, the treatment doesn't stop after 6 weeks. This treatment continues after 6 weeks as well. But we have learned over the past 25 years of TMS research is that once we are able to make those connections stronger, then patients don't necessarily need that treatment every day. Even if they get it periodically, it keeps those connections strong. And again, that is highly individualized. Mm-hmm. We typically decrease the treatment frequency to 3 treatments a week, then 2 treatments a week, then 1 treatment a week, then perhaps 1 treatment every other week. And we slowly wean it down and find out where there is peak benefit and the patients don't decline. So we need to adjust the dose, and it's a process over months of fine-tuning and adjusting the perfect dose for the patient.
I'm certain that patients, before they go into this or while they're doing it, want to know, will this help? Will this help? What do you tell them? Do you tell them this will positively help? It might help. It might not help. How do you deal with them candidly about this process?
The clinical trials that led to its approval for, say, depression showed that 60% of the patients had a significant or meaningful improvement in their symptoms. And now we started our program in 2020, so we have 5 years of our own data, and our data shows that about 7 out of 10 or 70% of the patients have significant improvement. Actually, more recent data, it's more than 70. Between 70 and 80% of the patients have a significant improvement in their symptoms.
How do you quantify that? How do you determine clinically they're better?
So there are tests that are done. Patients fill questionnaires. We calculate their depression inventories, scales that we routinely obtain on the patients. For other problems, there are other scales and inventories. So there's objective evidence. Okay. Plus, they continue to see their primary psychiatrist. The psychiatrist on our team reevaluate the patients periodically. Each patient is completely evaluated every 2 weeks from how they're responding to individual treatments, looking at the big picture, how their scales are trending, how their mood scores are trending. We take into account the feedback from their primary psychiatrist. We provide them feedback from their treatment sessions. So it's a collective effort. There are a lot of people involved in the taking care of one patient.
Wow. Do you beyond the clinical part, Do you hear from patients, or do you hear people say things like, I was able to go back to work, I improved my relationship with my spouse or my family, I could sleep again, I wasn't tearful for reasons I couldn't understand? Do you hear stories like that?
Every day.
Every day?
Every day. And some of our patients have actually shared stories with the media as well in the past, and it's just remarkable. It's remarkable. And I'll share a story with you since you brought it up. We have a patient who's been receiving this for several years, and she would cross this bridge on her way to work every day. And she tells us that every day she would think about driving off the bridge. And then she started receiving TMS treatments, and about 4 weeks into the treatments, she was on her way to work, and she realized, or she noticed how beautiful the view was from the bridge. And she realized that this was the first time she had recognized how beautiful the view was from the bridge. And she pulled over, and this made her cry. And she shared this powerful story with us. And it's remarkable how the difference patients experience.
How does that make you feel?
Humbled, and very fortunate to be part of such an extraordinary team that takes care of our patients and takes our mission to heart, to improve the lives of West Virginians. We have several patients who were not able to work, who were just in a downward spiral, and after the treatment, they're back to work on their feet. We have extraordinary ambassadors of our program out in the community, and almost every month we get referrals who are actually patients coming in because they heard the story from one of our patients.
Really? Does this also work for chronic pain?
Yes. So the two FDA-approved indications currently are treatment-resistant depression and OCD that we treat in a clinical program.
Behavior.
Obsessive compulsive disorder, that is OCD. But there are several other off-label uses where there is plenty of data to support its use in the treatment of those disorders. But the treatment of those disorders is so complex, depending on each patient and the expertise of the providers, that the industry has not sought commercial approval for those. Okay. But we are very fortunate that we have the expertise here, both from a technology standpoint and the experience standpoint, that we do offer this for chronic pain. These would be, again, patients who are refractory to treatments, and in stroke rehabilitation. We have had remarkable successes in patients, especially with aphasia, who have problem speaking, and then certain other problems as well.
That, as you indicate, that must be much more complicated because different parts of the brain, right?
Yes.
And you have to find those parts.
Correct. So, for instance, in stroke rehabilitation, oftentimes the degree of stroke can vary between patients. Some patients may have a large area that's damaged because of stroke, whereas some patients may have only a small area that's damaged because of stroke. So finding appropriate targets where it can be safely delivered without causing any unwanted side effects, and then defining goals from the treatment. So these can be very complex. So that's why it's very difficult to generalize it for something like stroke rehabilitation. But again, we are very fortunate, and West Virginians are very fortunate that we have the expertise over here where we can offer it on a case-by-case basis.
Doctor, this is there are some remarkable things that are being done at WVU Medicine and at Rockefeller. And what gets you up and going to work every day?
This sense of purpose.
Sense of purpose.
Sense of purpose. I often talk about this with my patients and my colleagues, that at the Rockefeller Neuroscience Institute, of course, we have extraordinary leadership Dr. Rizai has he's just led this charge of innovation and service to the patients, to West Virginians. But there's this pride and sense of purpose that most of us have, and it's just the team spirit. It's humbling.
Do you think that's reassuring for patients as well?
Oh,
that they see that, they feel that?
Absolutely, and patients do feel that, and patients share this with us. It's remarkable. So, like most clinics, our clinic hours, at the Rockefeller Neuroscience Institute Innovation Center building, we have a state-of-the-art TMS clinic, and we have a state-of-the-art TMS research lab. Both of these have integrated neuronavigation, so systems that can use the scans of the patients to, integrated with the system, integrated electromyography, where we can see the muscle activity as we're doing the treatments, integrated electroencephalography, where we can see the EEG changes. So state-of-the-art clinical program and research program. And for our clinical program, like most of the clinics, the hours are 8 through 5, right? Every day. Mm-hmm. But our clinic starts at 7 in the morning. And I have no role to play in that. And this was all our team, because some of our patients work, and they requested if it was possible for them to come in early. And one day I received this proposal, if it was okay for the team members to come in early and treat these patients. And this is an example that gets me up every morning, because I get to work with these extraordinary people who take this initiative, who want to help the people, who want to help the patients, and serve the people of our state. So we start early. Some days we end late. But it's just remarkable how the team members, they want to help, and they want to do the right thing.
Yeah. Thank you, Doctor. Thank you. Thank you, Dr. Najib. If you'd like more information on TMS treatments, you can go to wvumedicine.org, or you can Google RNI. You can find out more information there. So for producer Chad Plauché Atkins, I'm Hoppy Kercheval. Thank you for joining us. We'll see you next time on The Boundless Brain.